Welcome back to the deep dive. Today, we're committing to taking some really crucial material, synthesizing it, and giving you that shortcut to expertise.
Mm,
And this deep dive is laser-focused. It's specifically tailored for you, the learner, who's getting ready to master the core concepts of community and population health nursing.
right.
We know you need to really understand these frameworks, not just, memorize them. You want to get to that A+ synthesis level.
That's absolutely our mission today. Population health, it fundamentally challenges the traditional reactive model of medicine.
Yeah, the one we're also used to.
Exactly. We're moving the conversation and the practice from just treating sickness to proactively building wellness. And to do that, you have to master the basics.
Okay, so what are we covering?
We're going to clarify the fundamental difference between what we call upstream and downstream thinking. We'll dissect the three distinct nursing roles in this space, analyze the massive impact of the social determinants of health.
That's a huge one.
Oh, it's huge. Then we'll break down the three essential levels of prevention, and finally, put it all in the context of the National Guide, Healthy People 2030.
So we've really pulled all 5 of your core learning objectives directly from the source material. We're going to make sure every single one is covered with the detail you need for true mastery.
Absolutely.
Okay, so let's unpack this. Our sources give us a really clear roadmap of what we need to achieve. First, we have to differentiate upstream versus downstream.
Yep. And why that mindset shift is so important.
Second, we'll explain the differences between public, community, and community-based nursing. I know that's a tricky one for a lot of students.
Very tricky, but essential for understanding scope of practice.
Third, we'll discuss the SDOH and the health indicators we use to measure their impact. Then fourth, list the 3 levels of prevention with some really rock-solid examples. And finally, describe the purpose and scope of Healthy People 2030. So let's start by setting the stage. Because understanding the challenges in the U.S. healthcare system really explains why this whole field of nursing even exists.
It's the why behind everything else.
Right. When most people think about healthcare, what they're picturing is what we call clinical care services.
The doctor's office, the hospital.
Exactly. This is the structure that defines that traditional U.S. model. And its main characteristic is that it's heavily reactive.
Right. You get sick, then you get care.
If you look at its design, it's primarily a fee-for-service model. You get services when you're already sick, which means the emphasis is just overwhelmingly on episodic treatment.
And this model, it inherently values costly, high-tech interventions. Think about it. Emergency room visits, complex surgeries, aggressive new drugs.
All designed to manage a crisis.
Exactly. Manage a crisis or treat a disease that's already established. And look, while that's necessary for acute issues, this approach, it fails spectacularly at keeping the population healthy over the long term. And financially, it's just unsustainable.
And that's the crucial contrast with public health services.
A completely different world.
Yeah, public health is the total antithesis of reactive care. It's intrinsically proactive. Its core focus is shifted entirely to health and wellness, disease prevention, and, promoting health across entire populations.
It asks a different question. It asks, what conditions do we need to create so people don't end up in the emergency room in the first place?
And that shift is so vital because when you look at the major healthcare challenges in the 21st century, the traditional model is just visibly failing.
We're really in a dual crisis. On one hand, you have these escalating costs that just keep spiraling out of control, eating up a huge amount of our national resources.
And on the other hand,
despite this massive spending, we are seeing increasing morbidity and mortality specifically from preventable chronic diseases.
things like type 2 diabetes, heart disease.
Hypertension, exactly. These diseases are the signature failure of a system that's built on treating sickness rather than promoting health.
So that brings up the big question. How does the U.S. system actually perform on a global scale with this model? Your sources had a pretty startling detail on this.
Yeah, the data is, well, it's unequivocal and honestly deeply concerning. When you compare the U.S. to other high-income industrialized nations, we consistently rank lowest in performance. Lowest across key health indicators. And it's not just one area. This poor performance is systematic.
So what does that include?
It includes low marks in overall access to care, poor administrative efficiency, and most importantly, low performance in healthcare outcomes, and critically, health equity. So this ranking tells us that even though we have some of the world's best technology, we're failing to translate all that spending into broad, equitable health improvements for our population.
So if the model is too expensive, too reactive, and it's delivering poor outcomes, there had to be a push for some kind of optimization.
There was.
And this effort came together in a pivotal framework from the Institute for Health Improvement back in 2008, the Triple Aim.
The triple aim. This is the foundational performance metric for the modern healthcare shift. It was designed to optimize the U.S. health system by demanding that organizations and policies address three dimensions simultaneously.
And you said the word simultaneous is key.
It's the whole game, because achieving all three at once often means managing some really inherent tensions.
Okay, so let's break down those three dimensions. First, we have enhancing the patient experience.
Right, which includes both the quality of care they receive and the patient's satisfaction with that care.
Okay, number one. What's number two?
Number two, and this is maybe the most immediate pressure point, is lowering healthcare costs. I mean, if the system is fiscally unsustainable, no amount of quality improvement matters in the long run.
True. And the third dimension, which is really what our whole deep dive is about today, is improving population health.
That's the one. This is the dimension that elevates community and public health from being, a secondary concern to being a primary system-wide goal.
You mentioned attention there. Can you explain that?
Yeah, think about it. If a hospital focuses only on lowering costs, what do? They might cut staff, they might cut essential services.
Which directly hurts the patient experience.
Exactly, and potentially population outcomes. But if they only focus on enhancing the patient experience, they might overtreat or overdiagnose, which drives costs way up.
So the Triple Aim forces leaders to balance all three of these often competing priorities.
That balancing act is the core challenge of modern health administration.
So a major legislative attempt to force this balance and really shift the system toward population health was the Patient Protection and Affordable Care Act, ACA, of 2010.
Right. The ACA was the most significant reform effort in decades, and it directly supported the Triple Aim goals by focusing on system-level changes. Its key provisions were really designed to dismantle the financial barriers that kept so many Americans reliant on that episodic, high-cost care.
Can you give us some details on those provisions, especially the ones that really push the system upstream?
Okay, so first and foremost, the ACA aimed to provide affordable coverage to millions of people who were previously uninsured. That massively increased access. But beyond just coverage, it aimed to lower costs overall by reforming payment models and, importantly, requiring that insurance plans cover preventative care and prescription benefits with no cost sharing for the patient.
Okay, that right there is the direct mechanism for upstream change. Suddenly, preventative services like certain screenings or immunizations were free at the point of care.
Exactly. Just imagine a middle-aged patient who, historically avoids a colonoscopy because of a high deductible or copay.
Happens all the time.
All the time. The ACA removes that financial barrier, and that allows the patient to access a secondary prevention measure, the screening that can catch early-stage cancer. Removing that financial disincentive is a massive policy shift that moves care upstream.
And it also covered pre-existing conditions.
Right, preventing patients from being penalized for chronic illnesses they already had, and it let young adults stay on their parents' plans longer. By increasing access and removing those financial penalties, the ACA really solidified this idea that health is a population-level concern, not just an individual transaction.
And that shift from transactional medicine to systemic health is what underpins our next section, the foundational mindset.
Perfect transition.
So these reform efforts show us that just treating individual cases isn't enough. To really improve population health, we need a complete shift in perspective. We need to move toward a systems approach. And this concept is central to understanding public health nursing. It means viewing the community, or any group really, as a whole system made up of interrelated parts.
And this systemic view is so critical because it moves the nurse's focus away from just the patient's bedside and toward the patient's whole environment, their neighborhood, the policy landscape.
So a change in one part affects the whole.
Inevitably. A change in one part, whether it's housing policy, employment rates, or the number of unvaccinated people, it impacts the health of the entire community. If a community doesn't have accessible, quality groceries, the rising obesity and diabetes rates, those aren't individual failures. They're a system failure.
That interconnectedness brings us right to upstream thinking. This is the core conceptual tool of public health. I think the best way to get this across is with the classic river analogy.
Yes, the analogy is brilliant because it's so simple. So picture a river. You're standing downstream, and you're just desperately pulling people out of the water who are exhausted and drowning.
A very reactive position.
Completely reactive. That act is necessary, of course, but those are downstream interventions. You're focusing only on the individual episodic treatment. This is where most of our clinical care services operate,
We manage the disease, treat the trauma, discharge the patient.
often knowing they're just going to fall back into the river.
Can you give a clinical anecdote here? Something that really hammers home that feeling of just clinical futility.
Absolutely. Think of a nurse in a busy city hospital, and they're constantly admitting the same patient with uncontrolled type 2 diabetes. It's leading to foot ulcers and eventually amputations.
A terrible but common story.
Then the downstream intervention is managing the wound, giving antibiotics, maybe performing the surgery. But the nurse knows the patient lives in subsidized housing with no refrigerator, relies on highly processed food from the corner store, and has limited health literacy because of a poor education.
All those structural issues.
Right. The economic stability, the built environment. They're pushing that patient back into the river every single time. Upstream thinking is asking the question, why are they falling in the first place?
What are the economic, the policy, the mental health factors at the head of the river causing this?
Exactly. The focus shifts from rescuing individuals to preventing the fall entirely by fixing those structural barriers upstream.
It's such a powerful concept, but this focus on environment and context, it's not actually new, is it? It has deep historical roots in nursing theory, starting with Florence Nightingale's environmental theory.
Oh, absolutely. Nightingale, working during the Crimean War, she observed firsthand how environmental conditions directly dictated patient outcomes. She fundamentally changed nursing from just custodial care to a profession centered on manipulating the environment.
So her core focus was that relationship between a person's environment and their health.
And she explicitly prioritized preventative care.
Her theory listed 9 specific environmental factors a nurse has to manage. Let's walk through these because they sound incredibly modern when you look at them through the lens of SDOH.
They really do. She emphasized ventilation and warmth, stressing the need for fresh air, proper temperature control. Sounds simple, but poor ventilation in crowded housing is still a major cause of respiratory illness today.
Right.
She noted the power of light, insisting that sunlight promotes healing and psychological well-being. This is a direct precursor to our understanding of the mental health impact of access to nature and green spaces.
And of course, cleanliness was huge for her. The hygiene of the patient, the bedding, a low environment to prevent infection. That's just foundational.
It is. She also included noise control, emphasizing that quiet promotes rest and recovery. We now know that's crucial for stress reduction and immune function. Nutrition was vital. A proper diet supports healing, a concept we're still struggling with in the context of food deserts today.
And what about the housing context? That seems to align perfectly with our modern concerns about the built environment.
Precisely. She detailed the health of houses, arguing that safe, sanitary housing prevents illness. That's a direct early concern about housing quality and its link to disease.
And the other factors.
The importance of bed and bedding clean, dry materials to reduce infection risk. She also included variety, which meant mental stimulation helps recovery, acknowledging that psychological component of healing. And finally, personal hygiene.
So bathing, grooming.
Promotes comfort and reduces infection. But what's amazing is the synthesis. Nightingale's work proved that the patient's immediate environment, their shelter, their food, their air, is the primary driver of their health. It was the first systematic articulation of upstream thinking in nursing.
So if Nightingale focused on the patient's immediate environment, the next big theoretical leap came from Nancy Milio's core ideas, which pushed that focus out into the societal and political realm.
Yes, Milio made that critical connection between the individual's environment and the societal structure. Her central idea is that health is profoundly shaped by the options that society makes available to people.
So people make choices.
They do, yes, but those choices are constrained by what is accessible, what's affordable, and what's encouraged by policy.
Which means that just educating individuals on how to be healthy is fundamentally not enough if the system makes those healthy choices difficult or impossible.
Exactly. Her key idea is that prevention works best when we intervene by changing environments and policies, not just by relying on individual education or behavior change.
Like with smoking.
The perfect example. Individual counseling helps a bit, but what truly drove down smoking rates were massive policy changes. Taxes, public smoking bans, advertising restrictions. Milio links health problems directly to a lack of health-promoting resources in the community.
I can see a direct line to the triple aim here. If we want to improve population health and lower costs, we have to follow Milio's mandate and tackle those policy constraints.
Absolutely. And this leads to her key assumptions, which are just central to population health. First, she assumes people choose from the options they have. They aren't inherently making bad decisions. Second, she argues that so-called unhealthy choices often reflect limited resources and major barriers, not just a lack of willpower. And third, and this is the most critical point, policy and power structures shape who gets access to health-sustaining resources.
Therefore, the nurse's role, especially the public health nurse, must be to target those upstream causes.
The policies and structures that create inequality, yes.
And that gives us her final, powerful model linking context to outcomes.
Right. Upstream determinants influence the real options available to a person, which dictates their behavior patterns, which ultimately determines population health. If you want to change the health outcome, you can't start at behavior. You have to start at the determinants.
Melio's framework provides the perfect bridge to the modern application of all this. The social determinants of health, or SDOH. This concept is really the global language we now use for discussing these structural barriers.
Yeah.
What's the precise definition we need to know?
Okay, the formal definition of SDOH is the non-medical conditions in the environments where people are born, live, learn, work, play, and age, which profoundly affect a wide range of health, functional, and quality of life outcomes and risks.
The key phrase there seems to be non-medical.
It's everything. We're talking about environment, socioeconomic status, education, factors that account for somewhere between 70 to 80% of a person's health trajectory.
70 to 80%.
Wow, it far outweighs the impact of clinical care alone. They are the systemic roots of health inequities.
That percentage is just staggering. It really confirms why this shift to population health is so essential. Your source material breaks these conditions down into 5 major interconnected factors. Let's analyze each of these.
Let's do it. We'll start with the foundational one, economic stability. This covers income, job security, and employment options. When you have chronic job insecurity or low wages, the stress that results is a direct physiological cause of poor health.
Can you give a concrete example of how that translates to poor health?
The clearest examples are food security and housing instability. Food security means you have consistent access to affordable, nutritious foods. If a person's income forces them to choose cheaper, highly processed, high-calorie food,
You see a direct rise in obesity, hypertension, diabetes.
instantly. And similarly, housing instability, constantly worrying about eviction or living in poor quality housing with mold or poor sanitation, is a constant source of physiological stress and exposure to disease. An economically unstable environment translates directly into biological risk.
Okay, so that's number 1. Moving on to the second factor, education.
Education covers both access to and the quality of education, literacy levels, and just overall opportunity. Education is often the gateway to economic stability.
And lower educational attainment means.
It correlates with lower health literacy. That makes it harder for people to navigate the complex health system, understand preventative measures, or manage their chronic diseases. High school dropout rates in a community are, for that reason, a very relevant health indicator.
Third, we have the determinant that is probably most often confused with health itself. Healthcare access and quality.
Right. And while SDOH are non-medical, access to care is still a determinant. This factor addresses whether people can actually get to a primary care provider, a pharmacy, or a hospital when they need to.
The idea of a health desert.
Exactly. If a patient lives in a neighborhood lacking these essential services, the risk of a preventable illness escalating into a crisis just skyrockets. And this can be geographical, like in rural areas, or financial, even with the ACA, if copays or deductibles are still too high.
Fourth, and this really reflects Nightingale's legacy, is the neighborhood and built environment. This is everything physical that's around us.
This is a huge category, and it's one public health nurses often target directly. It includes the availability of green spaces like parks, trails, bike racks, which directly impacts physical activity.
It also covers housing quality.
Yes. Is it safe, stable, lead-free? It addresses proximity to pollution. Living near factories or major highways leads to increased asthma and cancer risks. And neighborhood safety is paramount.
Because if a neighborhood isn't safe,
People can't engage in outdoor activities, so you see more sedentary behavior, more isolation. The source specifically mentions not having a close grocery store or adequate public transportation as core examples here, showing how infrastructure determines health behavior.
And finally, the fifth factor, which is often the most subtle but maybe the most influential, social and community context.
This factor addresses the quality of relationships and interactions within a community. It includes social cohesion, how connected people feel, the strength of support networks, community engagement.
And crucially, it includes discrimination and racism.
Absolutely. It involves the presence, or hopefully the reduction of discrimination and systemic racism. If an individual or a group constantly faces discrimination, that persistent stress response, what we call allostatic load, directly impacts their physical health, leading to higher rates of cardiovascular disease and premature death.
So a strong community is a buffer.
A strong, cohesive community provides a buffer against stress. A fragmented, discriminatory one is a direct health hazard.
And the impact of these 5 determinants is measured using health indicators. Why are indicators so important for this work?
Health indicators are the measurable outcomes that tell the story of a community's health. They do 2 critical things. First, they describe the current health status, the severity of problems, and second, they serve as benchmarks or targets so public health efforts can track improvement.
So if you implement a policy,
If we implement a policy related to, say, economic stability, we measure the change in a corresponding indicator, like the rate of food insecurity, to see if it worked.
what are some of the most common indicators that public health nurses are looking at?
They include fundamental things like mortality rates, overall life expectancy, the prevalence of specific diseases. But they also include behavioral indicators like average body mass index, BMI, rates of substance use disorder, SUD, and tobacco use rates. Monitoring these lets public health nurses diagnose community problems and focus resources where they're needed most.
So we identify the SDOH problem using indicators, and then public health uses various strategies to improve those determinants.
Yes, and these strategies are just pure upstream thinking in action. Instead of waiting for a patient to have a stroke, we implement public transportation systems so low-income residents can get to their appointments and to grocery stores.
Or advocating for affordable insurance.
Exactly. Or we establish Narcan distribution programs to counter the impact of SUD. And we use things like pop-up screening events to bring preventative care directly to underserved populations, reducing those geographical barriers.
And this entire systemic, data-driven, proactive effort, it's all synthesized under the term population health management.
Right. This concept moves beyond just public health services by integrating the clinical world with the community world.
That was it defined.
Population health management is defined as the process of improving clinical health outcomes of a defined group of individuals, a population within an integrated clinical health system.
And the key distinction there.
The critical distinction is that it explicitly moves beyond treating individual disease and demands that we include and address the social determinants of health. It's about using the enormous resources of the clinical system, hospitals, data analysts, nurses, to manage the health of a population, not just the illnesses of the patients who walk in the door. It requires coordinated care and targeted interventions based on SDOH data.
We've established the upstream mindset and the structural challenges, but who is actually doing this work? We know the American Nurses Association, ANA, sets the scope and standards for all professional nursing practice, specifically in the public health nursing. Scope and standards of practice.
That's the authoritative guide.
But within this sphere, there are 3 distinct roles. And for you studying for your test, differentiating them is absolutely crucial.
This is a really common point of confusion, the difference between public health nursing, PHN, community health nursing, CHN, and community-based nursing, CBN. So we need crystal clear boundaries defined by their focus, goal, approach, and setting.
Okay, let's start with the broadest and most systems-oriented role, public health nursing, PHN.
A PHN is fundamentally about prevention at a massive scale. Their focus is the population as a whole, often a geopolitical unit like a county, a state, or even the whole nation.
In their goal.
The goal is massive: to prevent disease, promote health, and protect entire communities. The approach is almost never direct individual care. It's about population-level interventions, policy development, advocacy, and working within government.
So their setting is usually a health department or a government program.
Exactly, local or state health departments. A PHN seeks community-wide structural change.
Okay, next up, let's look at community health nursing, CHN. This seems to be the critical link that applies that population data to specific groups.
Correct. A CHN occupies that middle ground. The focus is on individuals, families, and groups within the context of the community.
So they're looking at the data but applying it to a smaller group.
Right, like the children in a school district or the employees at a factory. The goal is to improve health outcomes by specifically linking individual care needs to population health data and community resources.
And their approach is more of a mix.
It's a balanced mix. Some direct care, but it's heavily weighted toward prevention strategies, health education, and resource coordination. You find CHNs in settings like schools, occupational health, community clinics, or outreach programs targeting specific groups like homeless veterans.
And finally, community-based nursing, CBN, which is essentially clinical care delivered outside of a hospital.
CBN is the most familiar role to traditional acute care nurses. Its focus is strictly on individuals and families who already have an illness or a specific health concern, and they deliver care in their natural settings.
So the goal is pragmatic.
Very. It's to manage illness, restore health, and provide comfort for those individuals and families. The approach is very direct care intensive, teaching self-care, wound care, medication reconciliation, and their setting is anywhere outside the acute care facility. Home health, hospice, primary care, it's illness management in the patient's own context.
To really solidify these distinctions, which again is vital for your test, let's run through the 3 practice scenarios from the source material and unpack the why behind each classification.
Great idea. Let's start with scenario 1. A home health RN visits Mr. T, a 72-year-old recently discharged with heart failure and diabetes. The nurse reconciles his meds, checks his weight and blood pressure, reviews his low-sodium diet, and assesses for home safety hazards.
Okay, this is unequivocally community-based nursing, CBN. The rationale here is the focus and the goal. The focus is a single individual, Mr. T, and the goal is managing his established illness, the heart failure and diabetes.
And facilitating his recovery post-discharge.
Exactly. The nurse is delivering direct care functions right there in the patient's home. The intervention is targeted at one individual's recovery.
Perfect. Now for scenario 2. A nurse with a neighborhood coalition reviews local hospital data and sees a rising trend in teen asthma ER visits. The nurse then interviews school nurses, teachers, and parents to identify triggers. After that, she organizes an asthma education program in local schools and partners with housing agencies and clinics for mold remediation and medication referrals.
This is clearly community health nursing, CHN. The nurse saw an individual problem asthma, but analyzed its prevalence within a specific group, the teens, and in the community context of schools and housing. Her approach is a mix, using population data from the ER visits to inform a group-level education program, and then coordinating resources by linking up with housing agencies. The goal is to improve the health outcomes for that whole group.
That's the perfect articulation. It bridges the individual issue of asthma with the community context of housing quality and the school environment. Okay, finally, scenario 3. A nurse sees epidemiological data showing increased pertussis cases across the entire county. The nurse works with the health department to investigate the new cases, coordinate mass vaccination clinics, communicates risk to the public through the media, and advises county lawmakers on policies to improve vaccine access.
That is the textbook definition of public health nursing, PHN. The focus is the entire geopolitical population of the county. The goal is protection and prevention of disease at the largest possible scale.
And the approach?
The approach involves policy advising, high-level data investigation epidemiology, and large-scale interventions like mass vaccination clinics. It aims to change the health trajectory of the whole community, not just one group or one person.
And understanding these scopes also informs the education you need. Generalist PHN practice often requires a BSN or maybe a generalist master's like a CNL.
But to be a true public health nursing specialist,
To be the policy leader, the epidemiologist, the program director, that requires advanced education focused on systems and policy analysis. So you're looking at an MSN, an MPH, a joint MSN-MPH, or even a doctoral degree like a PhD, a DNP, or a DRPH. This advanced prep reflects the high-level policy and advocacy skills you need for real upstream impact.
it's now that we know who is doing the work, we need to understand the structural process they follow. Public health work is guided by a standard framework, the 3 core functions of public health. This is the cycle of improvement for all population-level practice.
Right. These 3 functions are sequential, but they're also cyclical. They provide the mechanism for turning that upstream thinking into real, actionable change. The first function is assessment.
The foundational step.
It is. You can't intervene effectively if you don't deeply understand the problem.
So what does assessment look like in practice for a public health nurse?
It's the rigorous process of gathering and analyzing health data. This includes using epidemiological statistics, like tracking mortality rates, disease prevalence, actively monitoring the community's health, and diagnosing and investigating health issues, tracing them back to their root SDOH causes.
It's the what is happening and why phase.
Exactly. For example, assessing the nutritional status of a community means collecting data on access to healthy food, identifying food deserts, and then correlating that data with obesity rates.
Okay, so once that robust data is collected and analyzed, the diagnosis is made. The system then moves to the second core function, policy development.
This is where the structural change happens, turning all that data into action, just like in the Milio framework. Policy development involves collaboration with lawmakers, community leaders, and stakeholders to create and enact public health policies.
So this could be legal actions.
It could be, like developing mandatory reporting laws for infectious diseases or mobilizing community partnerships to create strategic plans for infrastructure, like building sidewalks or improving public transport. This is the moment when the nurse acts as an advocate and a systems thinker.
And the final function, which I think often gets overlooked, is assurance.
Assurance is the follow-through. It is the crucial function of ensuring that the necessary services and protections are accessible and actually delivered to the entire population.
So this means
This includes linking people to needed clinical care, assuring there's a competent public health workforce available, and enforcing health laws like checking restaurant sanitation or making sure environmental safety standards are met. And critically, equity is central to assurance. The goal is ensuring that resource distribution and access are fair and just.
these core functions guide the application of specific public health interventions. And we're not talking about like nursing procedures in a hospital here. These are strategic, population-focused actions.
Correct. Interventions are actions taken on behalf of individuals, families, communities, and systems to protect or improve health status. They are population-based, meaning they're designed to impact more than one person, and their primary focus is always prevention.
And the intervention wheel is a model that helps us understand how these actions are targeted.
Right. They can be focused at the individual family level, like case management, the community level, like a health fair, or the systems level, like policy development.
And the wheel covers a huge range of actions, from surveillance and screening to health teaching and the more upstream things like advocacy and policy development.
They are the tactical tools PHNs use to execute the core functions. And the common thread linking all of this is disease prevention. Now, the source material makes an important distinction here. We have to differentiate between chronic versus acute diseases and communicable versus non-communicable diseases. The prevention strategies will apply differently.
This brings us to probably the most vital concept for synthesis and application on your test, the levels of prevention. These 3 levels are defined solely by the timing of the intervention relative to the disease process.
Let's nail these down. Starting with level 1, primary prevention. This is the highest level of upstream thinking. The goal is to stop the problem before it even starts. The timing is before the onset of disease. You can use the mnemonic. Prevent disease.
The intervention removes the risk factor entirely. Classic examples are hand washing, mandatory childhood vaccinations, or educating adolescents on STI prevention.
A great example for older adults is placing railings and non-slip mats in the home to prevent the initial fall and injury. The person is assumed to be healthy, and we are protecting that healthy state.
Okay, so moving one step downstream, we hit level 2, secondary prevention. This is when a risk factor or disease might be present, but it's still early or asymptomatic.
The focus here is early detection and intervention to stop the progression or reduce complications. The mnemonic is screen plus light disease.
This is where most standardized screenings fall. Examples like mammography screenings, yearly checkups, pap smears, or an A1C check for prediabetes.
Right. We are looking for the problem, usually with a formal test, to catch it before it becomes symptomatic, costly, or debilitating. For older adults, an example is screening for unexplained bruises or broken bones, which could suggest elder abuse or undiagnosed falls that need immediate intervention.
Now, you pointed out a key nuance here.
I did. The application matters. When you're screening for prediabetes, the nurse is using a secondary prevention method, the A1C test. But the teaching that comes after, if the results are normal, might involve diet and exercise education, which is technically primary prevention of diabetes.
That's a crucial synthesis point for the A+ learner. The level is defined by the goal of the action, not just the action itself. Okay, finally, level 3, tertiary prevention. This is purely downstream, but it's still essential.
Right. The disease is established and the goal is to manage it, to limit disability, or to prevent recurrence. The mnemonic is treat plus disease.
This is the most common form of care in the clinical setting.
Absolutely. Examples include complex treatments like chemotherapy for cancer, physical therapy after a stroke to regain function, or enrolling someone diagnosed with substance use disorder in rehab or AA. The disease or damage has occurred, and the focus is on rehabilitation, maintenance, and preventing further deterioration. If you are managing complications, you are practicing tertiary prevention.
So we have the mindset, the tools, and the people doing the work. But we need a coordinated national effort to make sure everyone is working toward the same goals. And that's where Healthy People 2030 comes in. Where did this massive framework come from?
Healthy People has a deep history. It actually originated with the Surgeon General's report way back in 1979. The federal government recognized the mounting costs and poor outcomes from reactive medicine and decided to create a proactive national health strategy.
And it's updated every 10 years.
Published every decade, yes. That ensures it stays relevant to emerging challenges.
So it serves as the definitive national guide for promoting health and preventing disease. Why is that 10-year cycle so important?
That cyclical nature demonstrates an evidence-based commitment. It shows that consistent, targeted disease prevention and health promotion efforts demonstrably lead to decreased health expenses and improved long-term outcomes for the nation. It sets measurable objectives so policy and funding can be tracked against national benchmarks.
And the scope of Healthy People is just vast, covering dozens of specific health concerns. What are some of the key topic areas lifted that show its breadth?
They range from fundamental access issues to really specific demographic and global concerns. You'll see topic areas like access to health services, adolescent health, issues of disability, global health collaborations, improving oral health, and ensuring robust family planning services. It touches every aspect of a person's life, which really reflects that deep SDOH framework.
And its impact is organized around a set of 4 overarching goals.
These goals set the strategic direction for the decade. First, to attain high-quality, longer lives free of preventable disease and disability, so pushing life expectancy and quality of life up.
Okay.
Second, to create social and physical environments that support health for all people. That's a direct link to the SDOH framework. Third, to promote healthy development and behaviors across all life stages, from infancy to older adulthood.
And the fourth goal, which is maybe the most central and profound one, to achieve health equity. We've mentioned this term a lot, but in the context of a national plan, what is the clear definition and implication of health equity?
Health equity is rooted in a fundamental commitment to social justice. It's the core belief that health is a human right and not a privilege.
And the definition?
The definition is precise. Health equity is the principle that everyone should have a fair and just opportunity to reach their full health potential. This means that social, economic, and environmental circumstances must not be allowed to create barriers to achieving health.
So that implies a distinction from health equality. Equality is giving everyone the same resources.
Right. While equity means giving different people different resources based on what they need to overcome specific barriers.
Okay, explain that more.
If we give the same resources to everyone, equality, the people with massive pre-existing SDOH barriers like housing instability or chronic discrimination will still fall behind. Health equity demands we recognize those systemic disadvantages and intentionally distribute resources to those who have been marginalized or underserved, ensuring they have the support they need to reach their full potential.
So it means reducing those disproportionate rates of chronic disease we see in certain populations.
Exactly. Disproportionate rates that often fall along lines of race, ethnicity, or income.
So Healthy People 2030 is really the ultimate upstream policy mechanism. It uses these national goals to force resource allocation and policy development toward Milieu's determinants.
It's the ultimate expression of population health. It demands that the entire system looks past the acute illness and asks the big question. What structures must we fix in neighborhoods, in education, in the economy, to ensure everyone has a just opportunity to be healthy? Without this national roadmap, the whole movement toward upstream thinking would lack coordination and measurable benchmarks.
That was a tremendous deep dive. We moved from the philosophical shift of upstream thinking all the way to concrete national policy objectives. If you're preparing for your NURS 335 assessment, remember the core synthesis points we covered today for that A+ performance. Focus on the core mindset. Upstream thinking is that philosophical shift from rescuing individuals downstream to addressing policy and environmental causes. Be able to differentiate the three nursing roles by their scope: PHN, population policy, CHN groups context, and CBN, individual illness management.
Master the timing of the three levels of prevention.
Right. Primary is preventing the onset, secondary is early screening and detection, and tertiary is treating established disease to limit disability.
We covered how the options society makes available, not just individual willpower, dictate health outcomes, that powerful idea from Nancy Milio. And this understanding positions public health nursing as a powerful, necessary tool for achieving equity and justice.
So we have a final thought for you to mull over.
We do. For you, the listener, consider the specific social determinants of health that are most impactful in your own community. Maybe it's the built environment, maybe it's local school quality, or neighborhood economic stability. Using Milio's framework, try to identify what single specific policy change, not just an education campaign, but a real policy, would lead to the most significant upstream improvement in health for your immediate community. Think systematically about how to repair the river and truly create health, not just treat disease.